So before I go into disorders, I want to tell something about normal structure. Normal anatomy. Embryologically, the thyroid gland arises from a big line invagination at the root of the tongue and grows downwards in front of trachea and thyroid cartilage to reach its normal position. Normal thyroid gland weight is 15 to 40 gram and is composed of two lateral lobes and connected with isthmus. Taxation of thyroid yellowish translucent. Now the histology. Lobules of colloid filled spherical follicles or acini. They are lined by cuboidal epithelium with numerous fine microvilli extending into the follicular colloid that contains the glycoprotein thyroglobulin. Major function of the thyroid gland is to maintain a high rate of metabolism, which is done by means of iodine-containing thyroid hormones, thyroxine, and triiodothyronine, T3 and T4. The thyroid is one of the most labile organs in the body and responds to numerous stimuli such as puberty, pregnancy, physiologic stress, and various pathologic states. Under normal condition, the epithelial lining of the follicles may show some changes, like resting phase is characterized by large follicles lined by flattened cells and filled with deeply staining homogeneous colloid, and secretory phase, in which follicles are lined by cuboidal epithelium and the colloid is moderately dark pink, and resorptive phase. It is characterized by follicles lined by columnar epithelium and containing lightly stained vacuolated and scalloped colloid that occurs in hyperthyroidism. The synthesis and release of the two main circulating thyroid hormones, T3 and T4, regulated by thyroid stimulating hormone, that is called TSH. The mechanism is iodine trapping by thyroidal cells involves absorbing the iodine from the blood and concentrating it more than 20-fold. And second number is oxidation of the iodine takes place within the cells by a thyroid peroxidase. Third is iodination occurs next. Microvilli level between the oxidized iodine and the tyrosine residue of thyroglobulin so as to form monoiodotyrosine and diiodotyrosine, MIT and DIT. Then coupling of MIT and DIT occur in the presence of thyroid peroxidase to form triiodothyronine and thyroxine, T3 and T4. Now, the disorders, thyroid disorders. Functional disorders, these are two types, hyperthyroidism and hypothyroidism. Hyperthyroidism is also called thyrotoxicosis. Now, hyperthyroidism or thyrotoxicosis. Hyperthyroidism, also called thyrotoxicosis, is hypermetabolic clinical and biochemical state caused by excess production of thyroid hormones. When T3, T4 levels are high, it is called hyperthyroidism or thyrotoxicosis. The condition is more frequent in females. Now, in the thyrotoxicosis, primary, diffuse hyperplasia or Graves' disease, hyperfunctioning multinodular goiter, hyperfunctioning toxic adenoma, iodine-induced hyperthyroidism, and secondary TSH-secreting pituitary adenoma. And there are some conditions which is not associated with hyperthyroidism, but it is associated with thyrotoxicosis. These are granulomatous thyroiditis, subacute lymphocytic thyroiditis, like this. For your exam purpose, it is important Graves' disease, hyperfunctional multinodular goiter, and hyperfunctional thyroid adenoma. These three are important. And these three are most common also. Now the clinical features of hyperthyroidism. Excessive level of thyroid hormone result in an increase in the basal metabolic rate. So what happens? Patient tends to be soft, warm and flushed because of increased blood flow and peripheral vasodilation. Cardiac manifestation are among the earliest and most consistent features. Elevated cardiac contractility and output, tachycardia, palpitation, cardiomegaly are common, arrhythmia such as atrial fibrillation. These are the clinical features of hyperthyroidism. And there are also low output heart failure, so-called thyrotoxic or hypertrophic cardiomyopathy, hyperthyroid cardiomyopathy. Overactivity of the sympathetic nervous system produces tremor, hyperactivity, emotional lability, anxiety, inability to concentrate, and insomnia. And proximal muscle weakness, it is called thyroid myopathy. In the GI system, hypermotility and reduced transit time leads to hyperdefecation, but it should not be confused with diarrhea. Diarrhea and hyperdefecation are not same. In thyrotoxicosis, it occurs hyperdefecation, not diarrhea. Ocular changes often call attention to hyperthyroidism. A wide staring gaze and lid lag are present because of sympathetic overstimulation of the superior tarsal muscle. And there are also true thyroid ophthalmopathy associated with proptosis, occurs only in Graves' disease. So this is a person with hyperthyroidism. You can see wide-eyed staring gaze caused by overactivity of the sympathetic nervous system, and this eye is swollen. This is due to loose connective tissue accumulation behind the orbit. That's why this eye is swollen. It is a very important feature of hyperthyroidism or thyrotoxicosis. The skeletal system is also affected. Thyroid hormone stimulates bone resorption, increasing cortical bone porosity and reducing clavicular bone volume. The net effect is osteoporosis and an increased risk of fractures. Now, thyroid storm. Thyroid storm is the abrupt onset of severe hyperthyroidism. It is called thyroid storm. This occurs most commonly in patients with Graves' disease and probably results from an acute elevation in catecholamine levels, as might be encountered during infection, surgery, cessation of anti-thyroid medication, or any form of stress. Patients are often febrile and present with tachycardia out of proportion to fever. Thyroid storm is a medical emergency. A significant number of untreated patients die of cardiac arrhythmia. Now, the laboratory finding. Lab finding, low TSH value accompanied by an increase in free T4. T3, T4 will be high, but TSH will low. The measurement of serum TSH concentration is the most useful single screening test for hyperthyroidism. In occasional patients, hyperthyroidism results predominantly from increased circulating levels of T3. It is called T3 toxicosis. Now, Graves' disease. It is also called diffuse toxic goiter. It comprises of hyperthyroidism or thyrotoxicosis, diffuse thyroid enlargement, and ophthalmopathy. Now, idiopathogenesis. Graves' disease is an autoimmune disease, And it is already stated there are many immunologic similarity between this condition and Hashimoto thyroiditis. I will discuss later Hashimoto thyroiditis. First is genetic factor association. Graves' disease has genetic predisposition, familial occurrence has been observed, and these genes are involved. HLA-DR3, HLA-DR3, HLA-DR5, CTLA4, PTPN22. Just remember the name of the genes. Now, autoimmune disease association with Graves' disease may be found in association with other organ-specific autoimmune disease. Hashimoto thyroiditis and Graves' disease are frequently present in the same families, and the two diseases may coexist in the same patient. So Hashimoto thyroiditis and Graves' disease can have in in one patient frequently. Now, autoantibodies. In Graves' disease, TSH receptor autoantigen is the main antigen against which autoantibody are directed. So, thyroid stimulating immunoglobulin, it binds to TSH receptor and stimulates increased release of thyroid hormone. Thyroid growth stimulating immunoglobulin, it stimulates proliferation of follicular epithelium. Then TSH binding inhibitor immunoglobulin, it is inhibitory to binding of TSH to its own receptor. Depending upon its action as inhibitory or stimulatory to follicular epithelium, it may result in alternate episode of hypo and hyperthyroidism. So these three are important: thyroid stimulating immunoglobulin, thyroid growth stimulating immunoglobulin, and TSH binding inhibitor immunoglobulin. Just remember the three names. Now, morphological features. Grossly, the thyroid is moderately diffuse and symmetrically enlarged and may weigh up to 70 to 90 grams. And histologically, epithelial hyperplasia and hypertrophy as seen by increased height of the follicular lining cells and formation of papillary infolding. The colloid is markedly diminished and is lightly staining. The stroma show increased vascularity. It is the microscopical picture of Graves' disease. You can see it is the colloid deficient follicles, epithelial hyperplasia, and papillary infolding. All three features are present in this picture. Now, clinical features. Thyrotoxicosis, ophthalmopathy, and dermatopathy. Ocular abnormalities are leg lag, upper leg retraction, tear, weakness of eye muscles, and proptosis. In extreme cases, the legs can no longer close and may produce corneal injuries and ulceration. Dermatopathy in Graves' disease most often consists of pretibial myxedema in the form of firm plaques. Now, goiter. Goiter means the enlargement of the thyroid gland. It is called goiter, caused by compensatory hyperplasia and hypertrophy of the follicular epithelium in response to thyroid hormone deficiency. The end result of this hyperplasia is generally a euthyroid state. In contrast to thyrotoxicosis occurring in diffuse toxic goiter or Graves' disease, though at some stages there may be hypo or hyperthyroidism. Two morphological forms of goiter are distinguished: diffuse goiter, that is called simple non-toxic goiter or colloid goiter, and nodular goiter. Nodular goiter is also called multinodular goiter or adenomatous goiter. Now, pathogenesis. The pathogenic mechanism of both forms of goiter can be considered critical since nodular goiter is generally regarded as the end stage of long-standing simple goiter. The fundamental defect is deficient production of thyroid hormones due to various etiologic factors described below, but most common is dietary lack of iodine. Most common cause is dietary lack of iodine. Deficient thyroid hormone production causes excessive TSH stimulation, which leads to hyperplasia of follicular epithelium as well as formation of new thyroid follicles. This is the pathogenesis of simple and nodular goiter. Lack of iodine or goitrogen, deficient thyroid hormone production, excessive TSH stimulation, cyclic hyperplasia involution, and diffuse goiter. Then repeated hyperplasia involution, then fibrosis of involuted areas, growth of hyperplastic areas, and nodular goiter. First diffuse goiter, then nodular goiter. Now diffuse goiter, the simple non-toxic goiter or colloid goiter. Diffuse non-toxic simple or colloid goiter is the name given to diffuse enlargement of the thyroid gland accompanied by hyperthyroidism. Most cases are in a stage of euthyroid, though they may have passed through preceding stage of hypothyroidism due to inadequate supply of iodine. So the main reason is inadequate supply of iodine. Now etiology. Endemic goiter, prevalence of goiter in a geographic area in more than 10% of population is termed endemic goiter. Such endemic areas are several high mountains regions far from the sea where iodine content of drinking water and food is low, such as in the region of the Himalayas. Now, the role of goitrogens. Goitrogens are substances which interfere with the synthesis of thyroid hormones. These substances are drugs used in the treatment of hyperthyroidism, and certain items of food such as cabbage, cauliflower, and cassava root. These are called goitrogen. These cabbage, cauliflower, and cassava root. Now, sporadic or non-endemic goiter, non-endemic or sporadic simple goiter is less common than the endemic variety. In most cases, the etiology of sporadic goiter is unknown. This includes the following: suboptimal iodine intake in condition of increased demand, as in puberty and pregnancy, then genetic factors, dietary goitrogens, hereditary defect in thyroid hormone synthesis and transport, that is called dyshormonogenesis, inborn error of iodine metabolism. So among these, suboptimal iodine intake and dietary goitrogen are the two most important causes. Now the morphological features. Grossly, the enlargement of the thyroid gland is simple goiter is moderate weighing up to 100 to 150 gram, symmetric and diffuse, and histologically, hyperplastic stage is the early stage and is characterized by tall columnar follicular epithelium showing papillary infolding and formation of small new follicles. Involution stage generally follow hyperplastic stage after variable period of time. This stage is characterized by large follicle distended by colloid and lined by flattened follicular epithelium. This is the simple goiter, diffuse non-toxic or colloid goiter, colloid filled cyst. These are colloid and these are unaffected thyroid, normal thyroid. It is normal thyroid. And these are some areas of hemorrhage and light brown parenchyma. Now the nodular goiter or multinodular goiter or adenomatous goiter. Nodular goiter is regarded as the eighth stage of long-standing simple goiter. It is characterized by most extreme degree of tumor like enlargement of the thyroid gland, and characteristic nodularity. The clinical features, dysphagia and choking occur due to compression of esophagus and trachea. Multinodular goiter produce most extreme thyroid enlargement and are more frequently mistaken for neoplasm than any other form of thyroid disease. In multinodular goiter, the thyroid become very large. Now, the etiology. Epithelial hyperplasia, generation of new follicles, and irregular accumulation of colloid in the follicles all contribute to produce increased tension and stress in the thyroid gland, causing rupture of follicles and vessels. This is followed by hemorrhages, cystic change, scarring, and sometimes calcification, resulting in the development of nodular pattern. Now, morphologic features. Thyroid in nodular goiter shows an asymmetric and extreme enlargement owing 100 to 500 gram or even more. The 5 cardinal microscopic features are nodularity with poor encapsulation, fibrous scarring, number 3 is hemorrhage, number 4 is focal calcification, number 5 is cystic degeneration. These are the 5 points. Nodularity with poor encapsulation, fibrous scarring, hemorrhages, focal calcification, and cystic degeneration. The gross image of multinodular goiter, areas of fibrosis and cystic changes. These are cystic changes and fibrosis. These are cyst. These are cyst. And fibrosis. These are fibrosis. Nodular goiter, multinodularity, incomplete encapsulation, hemorrhages, scarring. These are multinodularity. These are also picture of multinodular goiter. It is the picture of simple goiter. Colloid distended follicles, these are all colloid, and flattened epithelium. Flattened follicular epithelium. Cut surface generally shows multinodularity, but occasionally there may be only 1 or 2 nodules. Histologically, partial or incomplete encapsulation of nodules, the follicles varying from small to large and lined by flat to high epithelium. A few may show micropapillary formation. Then areas of hemorrhages, hemosiderin latent macrophages, and cholesterol crystals. Fibrous scarring with foci of calcification, micro-macrocystic changes. The microscopic appearance includes colloid-rich follicles lined by flattened, inactive epithelium and areas of follicle hyperplasia, accompanied by degenerative changes related to physical stress. Now, the clinical features. Clinical features, goiters may cause airway obstruction, dysphagia, and compression of large vessels in the neck and upper thorax. That is called superior vena cava syndrome. Now, the thyroid adenomas. Adenomas of the thyroid are typically discrete solitary masses derived from follicle epithelium, and hence they are also known as follicular adenomas. In general, follicular adenomas are not forerunners to carcinomas. Nevertheless, shared genetic alterations raise the possibility that at least a subset of follicular carcinoma arises in pre-existing adenomas. Now, pathogenesis. Somatic mutations that lead to constitutive activation of the TSH receptor signaling pathway, gain of function mutations most often in the gene encoding the TSH receptor TSHR and less commonly alpha subunit of GNASH cause follicular cells to secrete thyroid hormone independent of TSH stimulation. That is called thyroid autonomy. Microscopically, the constituent cells often form uniform appearing follicles that contain colloid. The neoplastic cells show little variation in cell size and shape or nuclear morphology, and mitotic figures are rare. Occasionally, the neoplastic cells acquire brightly eosinophilic granular cytoplasm that is called oxyphil or Hargle cell change. The hallmark of all follicular adenoma is the presence of an intact, well-formed capsule encircling the tumor. Careful evaluation of the integrity of the capsule is therefore critical in distinguishing follicular adenoma from follicular carcinoma, which demonstrate capsular or vascular invasion. In follicular carcinoma, there will be capsular or vascular invasion involvement. But in follicular adenoma, capsule will intact. It is the solitary, well-circumscribed nodule is seen. You can see here, capsule is intact. And these are the myxoid stroma and follicles. It is the follicles resembling normal thyroid parenchyma. This is the Hargle cell or oxyphilic adenoma. These are Hargle cells. Abundant eosinophilic cytoplasm and small irregular nuclei. Now, the hypothyroidism. Hypothyroidism is a condition caused by a structural or functional derangement that interferes with the production of thyroid hormone. The prevalence increases with age and it's nearly tenfold more common in women than in men. Now the cause of hypothyroidism, primary and secondary for your exam point of view, autoimmune hypothyroidism or Hashimoto thyroiditis and iodine deficiency. These are the only important for you. The clinical manifestation of hypothyroidism, depending upon the age at onset of disorder, cretinism or congenital hypothyroidism, and myxedema is the adultic hypothyroidism. Cretinism, a cretin is a child with severe hypothyroidism present at birth or developing within first 2 years of postnatal life. This is the period when brain development is taking place. In the absence of treatment, the child is both physically and mentally retarded. Pathogenesis. Developmental anomalies, example thyroid agenesis and ectopic thyroid, genetic defect in thyroid hormone synthesis, defect in iodine trapping, oxidation, iodination, coupling, and thyroid globulin synthesis. Endemic cretinism is regions with endemic goiter due to dietary lack of iodine. Then clinical features. The clinical manifestations usually become evident within a few weeks to months of birth. What are the clinical features? Slow to thrive, poor feeding, constipation, dry smelly skin, hoarse cry, and bradycardia. As the child ages, clinical pictures of fully developed cretinism emerges characterized by impaired skeletal growth, consequent dwarfism, round face, narrow forehead, widely set eyes, flat and broad nose, big protuberant tongue and protuberant abdomen. And there is also Gap mutism, spasticity, mental deficiency are more evident. And lab findings, rising TSH level, falling T3T4 levels. Myxedema. The adult onset severe hypothyroidism causes myxedema. The term myxedema connotes non-pitting edema due to accumulation of hydrophilic glucopolysaccharides in the ground of substance of dermis and other tissues. Clinical features: the onset of myxedema is slow and a fully developed clinical syndrome may appear after several years of hypothyroidism. The striking features are cold intolerance, mental and physical lethargy, constipation, slowing of speech and intellectual function, puffiness of face, loss of hair, and altered texture of the skin. Lab finding, low serum T3 and T4 and elevated TSH level. Now, Hashimoto or autoimmune chronic lymphocytic thyroiditis. Three features: diffuse Goiter enlargement of the thyroid, lymphocytic infiltration of the thyroid gland, occurrence of thyroid autoantibodies. Hashimoto thyroiditis occur more frequently between the age of 30 and 50 years and approximately 10-fold preponderance among females. Pathogenesis. Hashimoto thyroiditis is an autoimmune disease, is well established. Hashimoto, a Japanese surgeon, described it in 1912 as the first autoimmune disease of any organ. Autoimmune pathogenesis of Hashimoto thyroiditis is explained by following observation, like autoimmune disease association, like in many autoimmune disease, Hashimoto disease has been found in association with other autoimmune disease such as Graves' disease, SLE, Sjogren's syndrome, rheumatoid arthritis. Immune expression of the thyroid cells and association of cytotoxic lymphocyte associated antigen 4 CTLA4 are T cell regulatory gene. There is initial activation of CD4 plus T helper cell, which can induce infiltration of CD8 plus T cytotoxic cells. Then detection of autoantibodies, thyroid microsomal autoantibodies, thyroid labeling autoantibodies, PSH receptor autoantibodies. Now, morphologic features. There is extensive infiltration of the gland by lymphocyte, plasma cell, immunoblast, and macrophages with formation of lymphoid follicles having germinal center, and presence of Hargal cells, also called astrology cell or oxyphil cell or oncocyte. These cells have abundant oxyphilic or eosinophilic and granular cytoplasm due to large number of mitochondria and contain large pulsar nuclei. Clinical features. The presenting features of Hashimoto thyroiditis is painless, firm and moderate goitrous enlargement of the thyroid gland, usually associated with hypothyroidism in a middle-aged woman. At this stage, serum T3T4 levels and diffuse and radioactive iodine uptake is also reduced. This is the picture of Hashimoto thyroiditis. You can see lymphoid follicle. These are lymphoid follicle, lymphoid cell infiltration, and these are Hargal cells.